Good evening, everybody. This is Dr. Ganga Dubey from the Department of Pediatric and Preventive Dentistry, Index Institute of Dental Science. Today, we are going to discuss about pediatric endodontics. Now, the introduction. What is pediatric endodontics? Basically, it is a science or a technology based with endodontic treatment of a deciduous primary tooth on young permanently in children. Now, before getting to know about the procedure and involved in pediatric endodontics, we should know the difference between primary and permanent. Now, first of all, the difference between parts of a primary and permanent. According to this pin in 1973, there are difference in the pulp chamber and the root canals of both primary and permanent teeth. The difference between pulse chamber is that in primary teeth the pulse chamber larger. The nasal pulse horn is more exaggerated and the pulse chamber follows the anatomy of the dentine of the tooth. So basically the pulse chamber is larger and the pulse horn, especially the nasal pulse horn in the first molar is very close to the dentinal area. And pulse horns are longer, they are more extended towards the cusp area. As I've already told, the pulse chamber follows the anatomy of your dentine. Now, mandibular teeth has larger pulse chamber and when compared to maxillary. And there is presence of accessory canals in the interradicular areas in primary teeth, and in permanent there are more accessory canals towards the apical nerve. And now the difference between the root canals. The root canals are more tortuous. The they are ripple shaped and they are large, slender, and mesodistal teeth. They are narrower in anterior teeth and they flare cervically because they need to, the root trunk is very narrow in case of primary teeth because they need to accommodate the permanent tooth behind. So the canals they flare cervically. Now, what are the general features of pulp? Pulp basically consists of soft connective tissue. And primary teeth, basically there are 20 primary teeth, so they have 20 pulp organs. The mean volume of pulp is 0.01 cc in incisors and more in molars compared to that of incisors. Now, the coronal pulp, the pulp that is present in the crown area. The coronal pulp basically has six surfaces, namely buccal, lingual, nasal, distal, the floor of the pulp, and the roof, roof of the pulp. And pulp horns, they just terminate in the buccal tip. Cervically increases with radicular pulp and height decreases with age. The coronal pulse, the height it decreases with as the age advances. Now the root part, that is the radicular pulse. The cervical region to root effect is the radicular pulse. They can be single and anterior teeth where single canal is single root is there, and in multiple in multi-rooted teeth like molars, and there is multiple canals. Continues to periapical tissue as the age advances. Dentine increases, the radicular pulse decreases, apical foramen becomes narrower, and cementum around the root it increases. Now, the apical foramen. The average size of maxillary is 0.4 mm and the mandibular teeth is 0.3 mm. Accessory canals are passed from the main root canal system to the periodontium. So basically, the accessory canals are basically the tributaries from the main root canal. They merge the flare towards various areas. So basically, they are accessory canals. And as the age advances, the accessory canals, there is interradicular bone alteration. So they, the number, they differ. Now, primary pulp organ. They function for a shorter time, average 8.3 years, because they shed. So pulp organ growth is time of crowning root development, that is 1 year. Pulp maturation after root completion till resorption. So pulp maturation is a continuous process. So after root completion till the resorption, it is the pulp is getting mature. So from increased vascularity and cellularity, from more differentiated cellularity and well-developed vascular supply, but less vascular supply. Now, pulp regression is resorption till exfoliation. So basically, there are three stages of primary pulp organ: pulp organ growth, pulp maturation, and then its regression. Now, for permanent pulp organ, it is crown complete after 5 years, 5 months, crown completion and eruption 3 years, 6 months, eruption and root completion at 3 years, pulp of permanency 12 years to the development of maxillary arch, it is increased, then mandible. Now, we have discussed the general features, that what are the anatomical differences between primary and permanent teeth, and where the accessory canals are located in the primary teeth, and what kind of anatomy of pulp is there in primary teeth. Like in coronal pulp, the primary teeth has a larger dimension, and pulp exposure is more. It has the pulp is more vascular and primary teeth, and there is the root, the radicular pulp is tortuous, the slender, and it's ribbon shaped. So this is the anatomy of the pulp. Now, before starting the pulpal procedure or pulpal treatment, we should know the etiology of pathology. Why does there is what is the how does the pulpal pathology take place, and what are the reasons? So there are many reasons. First is the first is physical. In physical, they can be mechanical, like trauma. Trauma can be accidental or by iatrogenic. Iatrogenic is that accidental, we expose the pulp while removing the carriers dentine, we expose the pulp. This is iatrogenic. Then pathological wear, cracked tooth syndrome, barometric changes, that is barodontalgia, that is the pressure changes when we go to high altitude, certain their pressure changes occur in the blood, and due to that there will be pulpal pathology. So in physical it is mechanical, then thermal. While cavity preparation, if we don't use enough coolant, if we do not use enough water, so it uh, produces heat. So due to that, there may be trauma to pulse. Then certain restorative cement have certain heat generation, so that may lead to pulpal trauma. And if we don't use a protective base and insulating base onto the floor of the cavity, then there may be pulpal trauma. And excessive polishing may be also lead to thermal injury to the pulp. Now, electrical to the galvanic. So if two different types of restoration is placed in the tooth, like amalgam restoration and turbocharge, so it may and there is an electrolyte in in the sense of saliva. The saliva acts as an electrolytic medium, and the other different types of filling, they act as electrodes, and so there is current produced as a circuit is formed, and current is produced due to which uh, it may lead to purple pathology. No chemical. Chemical is certain acids and monomers like we use in our dental materials, so phosphoric acid and monomers, etc. and the use of excessive drink, harsh drinks may lead to erosions and they may lead to pulpal pathology. So that is chemical. So first that was physical. In physical it is mechanical, thermal, electrical, and chemical. In chemical the use of acid and erosions. Now bacterial. Bacterial are microorganisms. That is toxin, direct invasion of pulp by caries or trauma or anachronism. That is microbial colonization and pulp by blood-borne microorganisms. Okay, so this is basically the bacteria. And miscellaneous, any other like hereditary, certain there is also pathology and idiopathic that does not have any etiology. So this is the etiology of pulp. Now basically what is the after pathology what happens? Basically whenever certain trauma or certain stimuli occurs in the pulse, like we have discussed the etiology, certain physical, chemical, mechanical, or any other kind of stimuli happens in the pulse. There is trauma to the pulse, there is injury to the pulse that may lead to inflammation. So after pulse inflammation, the inflammation of the pulse may cause various signs. Signs like signs of inflammation, basically pain, swelling, um, change in color, and production of temperature changes. So these are the signs of inflammation. So after this kind of trauma, there may be inflammation of the pulse, and inflammation may result to peripheral signs of pathology. So how to diagnose pulse pathology is an indication. First is subjective. First of all, you should take the proper history of the uh, from the patient, what is happening to the patient. So first is history of pain. So in pain, what is the type of pain, the duration, how long the pain, from how long the pain is occurring, the frequency, when it occurs, and how frequent is the pain, then the location, whether it's in the single tooth or it is referred to ear or head or lower mandibular area, and the spread, how far it's spreading. If the referred pain, then the aggravating factors. From what, from after eating ice cream, the pain is increased, or by cold drink, the pain, or by hot drink, the pain is aggravating. So these are the aggravating factors and the relieving factors. See how the pain is being relieved, like by taking medications or by changing the posture, the pain is relieved or not. Or by removal of the stimulus, the pain is relieved or not. Now, these are the subjective symptoms. Subjective means that you can ask the patient. Now, objective symptoms is what we can visualize by our own self. How to judge. So the objective symptoms are basically visual and tactile. Visual we see and tactile we feel. So the visual and tactile symptoms are three C. The change in color, contour, and consistency of the fruit and the surrounding tissue. CCC. 3C. Color, contour, and consistency. In color, if any color changes like reddish color occurs in a normal healthy saliva, contour of the never change in it, or consistency like fluctuant swelling is present on the tooth and surrounding tissue. Any sinus, crack, caries, or cracks are present in the tooth. So we can visualize that and we can feel the thing. Now swelling can be intraoral and extraoral. Now palpation. Fluctuant and enlarged tissue. The present intensity of location of frame can be visualized by the help of palpation and in other lymphadenopathy and the bony architecture also we can judge. Now percussion. Percussion is basically we see the inflammation of the periodontal ligament. But percussion the tooth if there is pain. So basically the periodontal ligament is inflamed. And percussion can be done by the help of a mirror handle or with the help of a finger. Vertical percussion, light percussion. If the patient is feeling pain or sensitivity on percussion, and if there is tenderness on percussion, so there is inflammation of the periodontal ligament. Mobility is also a science of orthopathology, but in case of pediatric patients, according to age, also we need to judge mobility because there is physiological mobility also in primary teeth. So mobility can be physiological or pathological, and mobility and integrity of the fiber attachment should be checked, and the degree of mobility should be checked. The degree of mobility can be checked with the help of a Wayman's index. Then we place two handles of a mirror on the tooth like this, and we check the mobility, horizontal, buccolingual, horizontal mobility, and buccolingual mobility, and visual distance mobility. So zero in case of horizontal and visual distance mobility is less than 0.2 mm. 1 when buccolingual is 0.2 to 1 mm. 2 when buccolingual is 2 mm. And 3 when it is more than 2 mm, and there is vertical mobility also present. So this is the mobility index, and mobility is also a criteria that signifies the further technology. Now, again, the last and final diagnosis of pathology can be a radiograph. Involvement of pulse can be significantly reduced. In this picture also, and then there is reduction. Here it is interradicular, it is the root canal is filled. So this is the radiograph. This is showing interradicular pathology, dental abscess, and whole pulp is involved. The radiograph also shows the pulpal involved. The last diagnosis can be also investigated. The vitality of the tooth can be checked with the help of pulse testing system, like cold test, like stream of cold air can be placed on the tooth, cold water bath at high fluoride spray or pallet can be placed on the tooth. Carbon dioxide ice check can be placed on the tooth to judge the sensitivity towards cold, and this is known as thermal test. So during the JAT in 1899. Now in heat take, we can warm stick of temporary stopping, we can heat and place on the tooth. Dry rotary coffee cup can be placed, it generates heat, and if the tooth is sensitive towards heat, we can judge it. Hot water bath, we can heat a burnish and place on the tooth. Hot compound, a hot gutta percha can also be placed on the tooth to judge whether the tooth is sensitive towards hot. Response to test. If there is no response towards heat and cold test, basically there is no sensitivity, then a tooth is non-white. Non-vital can be calcific, open effects, trauma, medication, this can be non-vital to anemia. If there is mild to moderate pain, then normal. If it's strong momentary pain, is reversible pulpitis, and moderate and strong pain is irreversible pulpitis. Now, electrical pulse testing. Basically, the electrical pulse test will just stimulate a delta sensory fibers. If there is positive response in electrical pulse testing, then there is vitality in the tooth. There may be a false positive response and false negative response also in case of electrical pulse testing. So we need to take care of that also. And insulin. 1978, he had done the studies and nearly 15 to 30% children was responsible electrical power testing. Now, anesthetic testing basically we test the difference between source of pain. If the patient is not able to specify from where the pain is occurring, we can give intralegamentary or infiltration anesthesia on that kind of route where we see a pathology. And then we can ask the patient if the pain is still persistent or not. So there is difference between anesthetic testing, sanctuary and mandatory. Now test cavity preparation. If you drill a tooth without coolant, if there is sensitivity, so the tooth is vital. So there is vitality. If there is no sensitivity, so we will continue towards surgical endodontic procedure. So this is called as test cavity. And the last one is physiometric test. It basically assess the pulse circulation rather than the integrity of nervous system. Blood supply basically, the oxygen supply and the blood supply basically gives us more idea of whether the tooth is vital or not rather than the nerve. So physiometric testing uh, take care of the blood supply of the tooth. Now pulse oximetry, basically pulse oximetry gives the blood oxygen saturation. A diode probe emitting two wavelengths is inserted on the tooth tissue like a probe, like your SpO2 probe. There is a probe that is present for the tooth. Red light is 63 nanometer, infrared 83 nanometer, and the microprocessor compare amplitude transmitted towards the infrared is to red light. Curve for oxygenated and deoxygenated. So basically, if there is less oxygen supply of the tooth, so there is certain amount of decrease in blood supply. So the saturation will indicate us that there is more deoxygenated blood present in the tooth. That is, the tooth is towards non-vitality. And there is also laser Doppler spirometry of the tooth. It also has certain wavelengths and certain wavelength judges the flow of your blood on in the pulse.